So, good afternoon, everyone. My name is Marc Royo. I'm an anesthesiologist within the Department of Anesthesiology and Critical Care. And I'd like to introduce our vision toward a virtual preoperative anesthesia clinic that we're calling Pre-Op Plus. I want to begin by asking each of you to think back to any experience either you yourself or a loved one has had with facing the prospect of heading to the operating room, and all the time, the visits, the travel, the stress that came along with that. Now, what if, on that culminating day of all that planning, your surgeon's partner in your care and the physician tasked with your safety in the operating room, the anesthesiologist, began to ask questions that insinuate it may not be safe to proceed today? What would that do to your confidence in your care plan? What are the ramifications of not removing that cancer today? This confusion on the day of surgery is an all too common problem, not only here at the University of Pennsylvania, but at hospitals all across the country. Now, some of our peer institutions attempt to address this exact scenario with a costly, resource-intensive, preoperative anesthesia evaluation clinic that schedules an additional office-based evaluation for nearly every patient that's scheduled for a procedure. But what if we could extract the value of that type of a visit without disrupting our current workflow or without any of the cost? To offer a little bit of context, over 25,000 cases are scheduled annually at the Hupp and Perlman Center operating rooms as elective day of surgery admissions or as outpatient procedures. Less than 1% of these patients will have the details of their medical history reviewed by an anesthesiologist in advance of their scheduled surgery. For the remaining 99% of patients, the first time an anesthesiologist reviews their medical record occurs when the OR schedule is finalized, which is 5 p.m. the evening prior to the scheduled procedure. While our surgeons do a phenomenal job compiling indicated testing or specialist consultation, a surgeon and an anesthesiologist worry about very different things, which is why the best surgical and anesthetic teams work so well together. But this delay in routing information to an anesthesiologist limits our ability to help our surgeons what they do best without significantly disrupting their progress toward the operating room. For our sickest and most complex patients, this leads to inefficiencies on the day of surgery, and we argue compromises patient safety. I'd like to better illustrate that point with a brief story of a 43-year-old gentleman who presented to the operating room for major abdominal surgery for recurrent cancer. Now, outside of the cancer, the only concerning diagnosis this patient endorsed or carried in his medical record was a history of chronic pain. Our surgeons did exactly what we would expect of them given our standard preoperative process. But on the day of surgery, the anesthesiologist begins to probe, and this patient is raising every red flag that he's at significant risk of obstructive sleep apnea. Combine that with his history of chronic pain, and the science tells us that this patient is at orders of magnitude greater risk of a pulmonary complication than many other patients and requires a unique care plan. What do we do with that information now that the operating room is ready to go? What we're talking about here is giving our anesthesiologists the opportunity to contribute their expertise in the preoperative preparation of the patients they are asked to keep safe in the operating room and beyond. Because our current system fails to consistently capture information in the medical record relevant to the anesthesiologist at no fault at all to our surgical colleagues, too much is left to be clarified on the day of surgery. Our solution is to mesh patient-reported information collected at the time of surgical scheduling with existing data within the patient's medical record to identify these highest-risk patients and triage them to an existing anesthesia consultation service, where a dialogue with our surgeons can begin on how to best prepare. To narrow our focus on how to identify these highest risk patients, we initially targeted non-inpatient day of surgery cancellations as a population emblematic of a failure of our current preoperative evaluation process. A 5-month review demonstrated 25% of cases canceled on the day of surgery could be classified as potentially preventable. Thematically, drivers of a cancellation or significant delay were unanticipated advanced cardiopulmonary disease, a history of an implanted cardiac device, a history of a quote-unquote difficult airway, and long-standing chronic pain. Using that information, we devised a patient-centered preoperative assessment tool to be completed in the surgeon's office at the time the patient is scheduled for their procedure that gets at critical information an anesthesiologist would want to know. The burden of the tool to the patient is no more than 4 minutes and does not require any guidance from a clinician. The goal here is to raise the floor in terms of relevant information available in the medical record for all patients presenting to the operating room and to catch the highest risk patients the moment we know that they're coming. To date, we've tested this tool in 2 surgical clinics with 27 patients screened. 22% of these patients had a history of significant cardiopulmonary disease, along the lines of a recent heart attack or a lung resection that would have warranted additional clarification on the day of surgery, essentially leaving decisions about how to care for and monitor these patients in the operating room until mere minutes before their scheduled procedure. With this tool, that guesswork disappears. 67% screened at intermediate or high risk of sleep apnea, a diagnosis that significantly increases their risk of an adverse event in the perioperative period. And only 1 of them carried that diagnosis in their medical record. We believe this is easily obtainable, highly relevant information that will benefit the care of all of our patients, and we've shown we can extract it without placing any additional burden on our surgical colleagues. When you scope this problem, we can talk about delays, cancellations, and the human cost. Depending on the accounting, each minute of fully staffed but unutilized operating room time averages approximately 12 to 30 minutes. In shifting the anesthesiologist involvement upstream for the most complex patients, we move the work to a much less costly point in time than the day of surgery. In my experience, this type of delay that this tool is getting at can easily prevent delays that exceed 30 minutes. If we say 3% of the 25,000 elective anesthetics at HUP and Perlman Center are met by this kind of a delay, those 750 cases cost the health system over $250,000 each year in inefficiencies. Our estimates suggest nearly 2 cases per week are canceled due to preventable reasons, meaning this same intervention could save approximately 100 patients and their families each year a potentially negative experience with our health system. And most importantly, with this tool, we avoid the immeasurable cost of potentially harming our patients. Our vision is to virtually push the pre-op clinic to the patient. We know that getting this information early is critical, but doing it at low cost is just as important. When we began this journey, we reached out to some colleagues at Brigham and Women's Hospital who have a model pre-op clinic, and they told us that if we could create a virtual clinic, they'd replicate it there. We think we're on the path to that virtual clinic and know our surgeons and anesthesiologists will provide higher value care when we get there.